Hello and welcome to the second webinar on calcification. We're in the University of Toulouse, where the Professor of Cardiology, Didier Carrier, is helping me observe two giants of cardiology do a very interesting calcified case, which has lots of learning features. We've got Nicolas Boudou, who'll be doing the case, ably helped by Emanuela Barbato. Can I have the first slides, please? So this is a patient with a calcified lesion. From the first webinar, these were the take-home messages, which was that if you're learning this game, the European consensus document is the place to start. It gives you all of the contemporary data on how to become skilled at looking after the calcified lesion, which is almost a day-to-day business in our aging population we look after. And the new rules are essentially that plaque modification using smaller bursides, slower speeds, shorter runs will give you good stent outcomes without the complications which have traditionally been associated with rotational atherectomy. And we talked a lot about complications, and the key message was to avoid them by learning how to do things properly. Just to give you a little hint, this is an angiogram of our case, which we're going to hear about in a moment. And if you stick with us during the webinar, we're going to have a masterclass, I hope, in how we can use modern skills of rotational atherectomy, intravascular imaging to deal with this in a safe and contemporary manner. So the aims of the webinar is to look at the clinical angiographic and IVUS evaluation of this patient with diffuse coronary disease with extensive calcification. We've got the new ROTAPRO system in place, and hopefully we're going to learn how to set it up and how straightforward it is and tips for clinical use. And then using the case, we'll go through hopefully the new rules for the European consensus document, ticking them off as we go along. This is an interactive webinar, and I hope very much you'll be able to ask your questions at any time, which will flash up in front of us. And as they come through, we'll try and answer them in a timely way, hopefully relevant to the timing of what's going on in the case. So as I said, the team here, Professor Barbato and Dr. Boudou, and Professor Carrier and myself, we've got the nurses in the lab, Lionel Roch and Patricia Malegari, and Jeremy Forres. Probably said that all wrong, but thank you very much for their contribution. Didier, you're going to tell about the case.
Okay, the case is represented by a patient who is 81 years old, and he arrived in our institution 5 days ago with an acute coronary syndrome and also congestive heart failure. And in fact, before hospitalization, he develops congestive heart failure class 2 NYHA, and he has also peripheral arterial disease, but which was only treated by medical treatment. He has a lot of risk factor with a prior smoking. He stopped smoking 10 years ago. He has also high blood pressure with 3 pills against hypertension, dyslipidemia, and he has also diabetes type 2 for a long time, because this diabetes starts 25 years ago. You can see the size and the weight of the patient with BMI of 27.7. Concerning the lifestyle, he is retired farmer, and he is at home, and he is an adept of long course in the forest to take mushroom. And concerning psychological status, he has no cognitive impairment. It's a very interesting patient, and we can discuss with him for a lot of subjects. Concerning the biology, he has a normal hemoglobin level, He didn't have renal failure with a creatinine clearance of 65 milliliters per minute. When he arrived in our institution, he was with congestive heart failure, and the level of NT-proBNP was high, 3,000 picogram per milliliter, with a high level of troponin T, because the normal range in our institution is less than 30, and he has 360 nanogram per liter. And also on this morning, we had the last level of hemoglobin A1C, which is 8%, with pills with Amarel, but also with insulin Lantus, and insulin Novorapid for a long time. The EKG was not remarkable, and consequently we didn't show the EKG because there is no Q wave. But at the echocardiography, there is an inferior akinesia, and the left ventricular ejection fraction was about 40% without valvular heart disease. And now you have the image of the baseline angiography.
Okay, so on the coronary angiogram, you can see a severely diffusely diseased right coronary artery, which peters out and has a subtotal occlusion in its distal course. But the inferior wall is compromised on the echo. And here is a diffusely diseased LAD, perhaps some concern with the proximal vessel, some involvement with the left main. And before the dye goes in, you can see the extensive amount of calcification seen. The SPECT scan showed despite the normal ECG, there's an inferior wall infarct with no viability. And so the function of today really is to optimize his coronary circulation on the left-hand side. And so we're going to go to the cath lab to meet our colleagues, where we'll look at the angiographic and imaging of this patient in some forensic detail. Nicolas.
I'm very happy to welcome you in our institution, in our cath lab, and I'm very pleased to work with Emmanuel Barbato. I have also to present all the team, Lionel, Jeremy, and Patricia, who will help us to perform this case. I hope we will be able to give you a lot of explanation, especially educative explanation. Maybe we can start with the angio. Emmanuel will present the angio.
Nicolas, shall we just say a word on the procedural setting here? We are with the transradial access, Adam and Didier, 6 French, ABU 3.75, I guess. Yes, 6 French as well, and these are the baseline angiograms that we have just acquired. What we noticed, and we were discussing this with Nicolas, is that as soon as we engage selectively with our guiding catheter, the ostium of this left main, we observed on the ECG, on the blood pressure monitoring, a dumping in pressure actually, that was not highlighted at the time of the diagnostic procedure. Nicolas was just telling me that they performed a diagnostic procedure with 5 French diagnostic catheters. So this can already let you suspect issues there. You see lots of calcium here, but the point comes when we see a cranial angio, cranial view. There you go. With empty coronary artery, with empty at the beginning of the injection, you can appreciate already at the fluoroscopy the amount of calcium that is present in this vessel, from top to toe actually. And you can also understand what could be the issue behind this dumping of pressure. There is indeed an ostial left main stenosis there that was not at all looked into at the time of diagnostic procedure. There is also a disease at the ostium of the LAD as well that we might need to discuss and assess, but it's really a long, diffuse calcified left anterior descending artery. If there is any comment from you, Adam and Didier, interrupt us at any moment during this angiogram. Do we have other projection, Nicola? Yeah. What we did, perhaps you can just inform on what we have done so far.
First, the pressure was quite dumping when we start, so we place a wire close to the inside the guiding catheter to be able to treat any dissection due to the stress of this intervention in a daily practice, but also doing a live. You can see the calcification. The circumflex artery is not diseased. There is a long calcified lesion inside the LAD, so we have to assess this just to better to highlight the need of rotablator, but also to better assess some lesion, especially in the left main. So we place our workhorse guide wire inside the distal LAD, as you can see, and then we disengage a little bit the guiding catheter to perform an IVUS to assess first the left main and then the long lesion in the LAD. We have to keep in mind that the RCA is occluded, and so we have to pay attention to this left main, but also to this huge LAD.
So it's quite common to find a lot of epicardial calcium on these elderly patients, but not always with a sort of obstructive lesion in the mid-course. In this particular case, because there's obstruction at the ostium left main, ostium LAD, extensive calcium with some stenosis perhaps severe in the middle, is that why you went ahead and did imaging rather than perhaps feel your way with a balloon?
Yeah, actually, that is a very good comment. We wanted to know upfront what should be our strategy instead of finding it out during the course of the procedure. You know, taking decision at this step might be key to the success of the whole procedure. We need to decide now whether we go for rotablator, yes or no, and we need to decide now from where to where we stand and whether we have to treat the left main as well. I mean, these are major decisions that we better are taken in an informed fashion. And that is why I think we rightly performed IVUS. We might see, perhaps we might first see on the fluoroscopy the way the IVUS catheter progressed during the lesion.
We start with the left main just to assess the lesion, which is quite, this is intermediate. The area is about 7 millimeters square, but also the RCA is occluded. So we both decide to treat this lesion, and then we try to engage the IVUS. You can see it was quite difficult to advance it. There is a lot of friction in this part due to the calcification, and especially due to the calcification, long calcification inside tortuosity.
Yeah, it seems promising, right?
Nicolas and Emmanuel, the first question, why did you choose PCI against surgical treatment with internal mammary artery graft in this case?
Because the patient is quite old, he is more than 80, and the LAD is diffusely diseased, so we have to discuss about 2 cabbages. We know that the RCA is occluded, and for this patient, due to the long lesion, we prefer to refer it to PCI, but I know we can discuss about cabbage. In the first angio, we didn't saw this left main. This is a mistake, but anyway, I don't think it changed our strategy.
Yeah, it's a
I
good
think you
question.
you can't ignore the morbidity of surgery in this age group.
Yeah.
Maybe the mortality is fine, but it's I think if you can get a successful percutaneous result, I don't think anybody would object in this age group that this is probably the first port of call rather than a surgical one.
If you agree, Adam, we would now show the IVUS pullback. We can show now the second run, the one that we started distal into the LAD. We can comment on it together. Let's. Do you have the IVUS image? I guess so,
yes.
right?
Yeah, the images are good, Emmanuel.
So we are quite distal in this part. Maybe Emmanuel, you want to comment?
Yeah, sure. That would be the so-called landing zone of our stent, which is perhaps the only segment free of disease, even though there is some plaque, as we have seen. Here we start to have some encroachment, but no major calcification. But you will see in a short while pulling back, here we have calcification between 5, well, much more, between 3 o'clock and 9 o'clock. But you will see shortly that there are even segments with 260 degrees calcification, so really 3 quadrants. So far we're still with 2 quadrants, and that was what really triggered our decision to do. Well, there you go. Here you have more than 2 quadrants involved, and that is for us a criterion good enough to start rotablation as a first intention. We discussed this with Nicola. Lots of plaque here from 2 o'clock till 9 o'clock. As we go back again, another big bunch of calcium, more than 3 quadrants at this level. There is no truly circumferential calcification in the LAD. We had the impression to see that at the ostium of the left main, but that might be also not the case because we were, I mean, the image is a little bit oblique. And again, calcium at this level from 11 o'clock till 6 o'clock, more or less. I guess we are approaching the ostium of the LAD. I still didn't see the circumflex coming in. That might be, yeah, that might be the circumflex, right?
I think this is still the proximal LAD, and maybe because maybe after we will see the...
Yes, but there is no discussion that this is a diffusely diseased and calcified LAD all the way down. Let's see whether we approach the left main.
Maybe we have to show you the first round to...
There we go.
Yeah, the
there we
carina
go.
and the
this is the carina, yeah.
Okay.
Okay, now let's see the first pullback where we only focus on the left main. And then we come back to you, Didier and Adam, to decide our strategy together. So this is the body of the left main. There is a nodule of calcification at 12 o'clock. And you will see in a short while, look at this, how encroached it is the ostium of the left main. We are not yet there. There we go.
No, there is, you
some
will see after, there is some artifact. Now we are in the mid part of the left main. You can see how it is diffused. And there is a short lesion in the ostial part, as you can see here.
Fully calcified also.
So maybe you can stop, reviens un petit peu en arrière, go back to the assessment of the lesion. Reviens à l'image qu'on a mesurée, this one. And you can see this is less, it's about 7 millimeters square, but maybe less.
Yeah.
It's sometimes difficult to assess in this part due to
it's
motion.
Not anymore coaction as well.
Yes.
That makes our assessment difficult. So what do you think about this IVUS pullback, Didier and Adam?
The new surprise is effectively the ostial nodule, calcified nodule on the ostial part of left main. Do you think that when you look at the IVUS, is your decision is modified concerning the left main? What do you think? Do you think that it's important to stent the left main or not?
The first thing concerning the calcification, long calcification in LAD and in the left main, I think it's better to prepare the lesion in terms of PCI, not to... and we have to prepare the lesion not with a balloon, but with rotative atherectomy. And thanks to that, we will prepare everything, the left main and also the LAD, and then we will be able to place at least 2 wires to finalize the PCI with balloon preparation and also stent implantation in the LAD, and I think in the left main. You know that the circumflex artery is not stenosis. There is a lesion in the distal left main, as you can see by IVUS, so we have to cover all the left main. I will show you again, maybe if you can see the angio, the circumflex artery, which is disease,
free of disease,
without any stenosis. So
which was the impression we also had at the pullback when we were at the level of the carina. So if you agree, we would proceed. What Nicolas has now has a workhorse wire in the LAD and has a rota wire, floppy rota wire next to it, and it will proceed live in placing the rota wire next to the workhorse wire into the LAD.
So this is a floppy rota wire. I have to engage a little bit the guiding inside the left main. You can see the pressure is quite
Is
dumping.
it possible to see the pressure when you engage the...
Sure. You see it now, that it is quite well dumped. This is the pressure we have.
Yeah. And when I engage...
Yes, it is an indirect sign about a lesion on the ostial part of the left main.
So I have to disengage because I just... we must have
the normal pressure of this gentleman is above 14 systolic blood pressure, and when we engage goes down to 80 or something.
Yeah, I have to manage the guiding catheter to avoid any dumping of the pressure, and also I have to avoid any sometimes if you engage too much a guiding catheter, you can induce a valvular leakage, an aortic valvular leakage. So this is not the case. The pressure is going down only due to the deep intubation inside the ostial lesion. So we have to pay attention to this during every time. So
so let me just share with the colleagues the tips and tricks of Nicolas. Looking at the table from above here, I can tell you Nicolas is moving, talking the rotor wire with the use of the rotor wire clip. And to avoid buckling this rotor wire, this long rotor wire, Nicolas preferred to leave the rotor wire within the plastic hose of the wire itself. So it prevents the wire to be kinked. You know, it's a more a 3 meter long wire. It might easily fall down the table, but by doing so, Nicolas has secured the rotor wire. Of course, we pay a little price in terms of freedom of torqueability, but you see, he's managing pretty well.
I will try to place the wire in distally under LAD. I have to avoid any angulation inside the small branches, especially inside the small septal, because using a rotablator you can break the wire. So you have to avoid any loop of the distal part of the wire. So I try to place it very distally. The pressure, my guiding catheter is disengaged, so the pressure is okay. And you know the rota wire is 0.010 inch, so the support is not very good. So you have to turn clockwise or counterclockwise to advance it slowly, maybe in a diastolic time. And okay, I think it's okay. So now
pretty good.
I will remove the floppy wire.
It's an important practical point
and
in the sense that exchanging
I will disengage the guiding because we have to prepare the ROTAPRO and discuss. And also I have to pay attention to the wire because I have to avoid any angulation of the wire which could compromise or decrease the crossability of the burr and the performance of the rotablator.
Nicolas, we've had a comment about exchanging the wire using a microcatheter or over-the-wire balloon.
This is a good option, of course.
And
this is a very good option. I use this in case of long lesion with subocclusive lesion, I mean, or in case of CTO. For this lesion, I don't think I need it, but if I have failed to advance it, it was our option to use even a microcatheter, but also an over-the-wire balloon, a small balloon, to exchange the workhorse wire with the rota wire.
Nicolas, I think now we need to decide on our rotablation strategy, and first of all, we need to decide on the bar size. What would be your first choice?
The ratio must be less than 0.6. You can see the distal LAD is at it's about 3 millimeter in the IVUS, so I think 1.5 millimeter burr will be the good option.
Yeah.
For the layman, we can discuss to use a larger burr, but I think to start it will be good. You know that there is a long lesion, so we need time to cross the lesion. So we have to prepare it. This is the ROTAPRO.
Could you show the old console of rotablator and the new one to explain the differences between both?
Les deux.
Yes, give us a second, Didier. We will just turn the camera towards the console. You have one by one, the two of them, the old one, the one below, the dinosaur, the previous version, and you have the new one above, which is much more catchy.
The first rotablator was done 30 years ago.
Right. It took some time, but we have
As
a
you
new
know.
version now. Black and white, and you will see while doing the procedure that there are lots of information that we can collect with the new system. So we are provided with interesting feedback, but let's prepare the system together as we go.
Okay.
Yeah. Go ahead.
Maybe you have to wait. Can you see the box?
Yeah. And
Okay,
perhaps
yes,
we can
okay.
We can see it well now.
So this is, we will use it. I will show you after. This is a clip. So, okay. So there is this part is quite huge, and you have to place it in the right way to be to ease the way to use this. So I will start by using this, and I put the clip, as you can see here, and I advance the burr in this part. As you can see here, I will clip here.
So the new cable is quite bulky, and
yes,
you just need to make sure it's well out of the way, and doesn't get involved in the mechanism.
Okay. Yes. Then there is no pedal, so I start to place the flush. I open it.
Can I ask you, what do you put in the flush, Nicolas, here?
So there is saline, nitro, and heparin.
Heparin, okay.
And
so we still have an air cylinder, yeah?
We still have an air cylinder. It's over there on the car.
Yes.
Perhaps if we move the camera towards the console, you will see the air cylinder.
And all the previous cables are all wrapped up now in the single,
yes.
cable to the new console. So that's
it
very
might
neat.
be worth. It might be worth to see now the system with the connection. So by turning a bit the camera towards the console, yeah, towards that direction over there, or you just advance
That's
a bit.
it.
Yeah,
Okay.
there you go. There you go. So you see the system, the three cables, and the air cylinder that is just hidden behind, but everything is there.
Okay.
And the beautiful thing is that there is nothing on the ground, Adam. No pedal. Everything is on the table now.
So first, I will remove the bubble of air, because sometimes it can induce, I think, distal embolization, and maybe you can see that there is a lot of small bubbles. So usually I do this to be sure. Yes, there is also bubble, because I think it can induce slow flow, especially if there is a lot of air inside the device. I think it's okay now. And to use it, in this button in blue, if you push, you start the burr. And there is two buttons for which is because when you start the water button, the wire is trapped, and to remove it, you have to push these two buttons to remove the trap, and also to induce a small speed when you want to remove it. But we will show you this after. So everything is ready. If you want,
shall we try just the speed, Nicolas, before we go?
I will just
elongate a bit the wire. Yeah,
okay.
the bar.
So if I push on the button, I start.
Yeah. Please look at the speed as well. That is on the console, because it comes now automatically set at 164,000 RPM. I think this comes also from a paper, right, Adam?
If you want to use a larger burr after, you can change with the old burr. The new device is the motor, not the burr.
Yeah.
This is the same. So now I will place the wire inside. I will place the burr on the wire. I will ask to to the nurse Lionel if he flush everything, because we discuss and we have to avoid any thrombosis. maybe I have to say that we inject 8,000 units of heparin to perform this procedure.
So the wire is out.
So now the wire is out. So I will use the torque in this. If you see my hand, and you can place it. Thanks to that, you can do a rotablator alone. If I want to, and for the Dynaglide, I will show you after. So then I can advance it. You can see my hand.
I think they have questions from there. Please go ahead, Adam.
There's a there's a little space to park the brake in the back of the. They had it on the old system as well.
Yes.
Not everyone uses it because sometimes it does cause a kink in the wire, which of course you need to avoid. But if you do it very carefully, it is quite convenient.
Yes. So this is my technique, but we can discuss. A lot of people have different techniques. Just to show what I do, if I do a loop with the burr and I pull the wire, and thanks to that I can advance it.
And I can tell, looking at Nicolas, I have a different technique, but it is quite convenient because with these two hands, he can manage it all. Huh? I mean, he doesn't need any help. And I don't know whether you can appreciate, the loop is becoming bigger here. And by securing the loop with the rotor wire clip in the hose there.
Some operator place the distal part of the wire inside the
plastic.
The plastic. Yeah. I do like this, but sorry, I have to check the
tip of the guiding catheter.
The guiding catheter, okay. Because I am okay. So everything is okay. And you know, I am using a radial approach. And there is also an ostial lesion. So, due to the tortuosity inside the guiding catheter, I can have some friction. So I will test the burr in this part. Mm-hmm. And usually, when you so I have to push in the button. There is no pedal. You will see the burr is sometimes advancing a little bit, and thanks to that, you release the friction. So it advances only 5 mm, but thanks to that, it will be easier to advance and to start. So I will just check in the ostial part. If you agree, I can start now, but if you want to discuss, I can wait if there is any question.
No, I think we should move on. I mean, in terms of engaging, you've got a lot of calcium here supplying an impaired ventricle. And you want to be careful with the amount of, you don't want any no flow here, any slow flow, any complications. You need to be...
Okay, so I start.
Yeah, off you go.
Let's go.
In the ostial part, I don't feel any friction. In the proximal LAD, there is friction. Okay, I wait. There is no friction, so I can keep the burr inside the left main. And
let me share with the colleagues these tips. There is this nice gentleman at my right who's informing Nicolas about the duration of the run, and you just shouted when we passed 10 seconds. I mean, that's a very nice trick that I wanted to disclose from the cat lab.
You know, the RCA is occluded, so the heart rhythm is quite decreasing, so we have to wait. And due to the long lesion, we have to take time between each run to have enough time to the calcification to go away from the microcirculation. So I will.
A question. Another.
Go ahead.
I prefer.
What do you? Wait.
Okay.
Yes,
just
please,
a question. What do you recommend concerning the speed of rotablation now?
So we agreed actually to have a speed between 135 to 180,000 RPM, but personally I prefer around 160, 170,000. How about you, Nicolas? The same. I don't know if you noticed, when Nicolas was ablating, there was this arrow popping up. It was an empty arrow, which tells us that the speed has gone down around 5,000 RPM, more or less. When the arrow is fill is full actually,
Yes.
then it means 10,000 RPM,
Yes.
right? So this is a warning sign for us that we might have too much deceleration there. And this, of course, we know might be portending complications.
You have also to listen the sound of the burr. And one advantage, I think, to the new ROTAPRO is you are doing everything with your right hand. So you have to pull back first the burr, and then you stop. And sometimes with the pedal, you can do both in the same time, and you can stop to the burr to run.
Yeah.
And this increases the risk of burr entrapment, I think.
Yeah.
So maybe it's a good option. Sorry, we are inside the lesson. I would like to advance a little bit.
Yes? Nicholas, you carry on. There's some questions here we'll field, Didier and myself. There's a thing. Okay. There's a question about you. Carry on, and
okay,
we can hear it over the noise. Do you recommend RotaGlide for the ROTAPRO system? Well, that's no longer available to us. It did make it very useful, I have to say, when we had it available. When changing burrs, do you need a new drive unit? No. The exchange mechanism for the changing of the burrs is exactly the same as the old system. So you keep the same drive unit throughout your case, even if you want to change 2 or 3 burrs. Perhaps, Didier, you could answer. There's been a question about whether or not pacing wire should be required in a case such as this.
Okay. We stopped to pace the patient since maybe 4 or 5 years, maybe more, because finally it's very short. But we perform a very short rotablation, 10 seconds, sometimes 15 seconds, no more. We wait, and if needed, we can inject atropine. I will only recommend to use pacing for patients with heart failure, maybe left ventricular ejection fraction at 20%. And if you do a rotablation in one vessel patent, if everything is occluded. But this is, and for patients with severe stenosis in the carotid, and maybe in case of severe valvular aortic stenosis. But usually we don't use it.
No, it's a big change, isn't
it? It's okay. Yeah. Maybe I can show you how to advance more distally the burr if you want.
Yeah. Yes, that'll be a nice thing to see.
So I start to advance it. I stop. I am in this part. With my left hand, I will block the shaft of the burr, and with my right hand, I will pull the wire, which is quite distal, and you will see the molette in French. I don't know the word in English. Sorry.
The knop.
The knop will go more distally.
So basically, you don't break it, right?
No.
You don't fix it. You let it
open. Yeah. And thanks to that, you can advance it slowly, more distally. Trick. And sometimes, especially in distal RCA lesion, it's difficult to advance the burr distally. So I will, and I do that after crossing the proximal lesion, of course. So, and thanks to that, I will go more distally, as you can see, very easily. Now the sound is very good.
It looks terrific.
So and, I think we will now place the workhorse guide wire. Maybe you have some question, some
yes.
comment?
How long do you wait after each rota?
Each run.
Each run.
With each run, yes.
The same time as the run. 10 seconds if this is 10 seconds.
How long do you wait before you do it again? Yeah.
30 seconds. Again,
yes,
this gentleman next to us is shouting in my ear saying 30 seconds. And then he knows that we can go on. Jerk.
I mean, essentially the message is short runs, be patient, avoid the complications of slow flow, isn't it?
Because you have to wait the macrocirculation release every particle. I will show you how to perform a dynaglide after, if you're okay. Maybe.
Okay, just another question. If you have a bradyarrhythmia, Do you use a treatment like aminophylline or not?
No.
No, never.
No. Well,
Okay, we
sometimes
wait.
we use atropine a bit if
Sometimes
needed,
atropine,
but not
ju
really
just atropine.
aminophylline.
Okay.
Yeah.
Yes.
Okay, let's have a look at the technique for getting the wire, the burr out.
So I will use the torque, as you can see, to
Release
avoid
the brake,
to release the brake of the wire. So I push this button, I push the torque, and you can see the button is
that releases the grip on the wire, doesn't it?
Yeah.
And
correct.
to perform to start the Dynaglide, you have to push on this button.
Yeah.
In the other side.
But
And
do we need to switch from the Rotoblader mode to Dynaglide mode first by pushing that one, perhaps? Yeah.
I push on the Dyna, and you can see the green light in this part.
Yeah.
And then I have to start by pushing this button, not the previous one. Is it clear?
It is. Interestingly, if you don't press the button and you press the Dynaglide operator, it won't work.
Right.
Yeah. So there's a safety mechanism in there to prevent that from happening.
Correct.
Yeah.
And then I can push the wire and pull back the burr.
Like we do with an over-the-wire balloon, actually.
You can hear the. I'm sorry, I would like to replace the guiding catheter because there is some yes, and the pressure is okay. So, and if you listen, there is it starts slowly. And I push the wire, and thanks to that, the burr is pulling back inside the guiding catheter. I prefer to keep an eye on the guiding catheter due to the lesion in the left main, and also I keep an eye on the pressure.
Out.
Okay, everything is out. So.
I don't know if you noticed, but so far we didn't use any single drop of contrast. Everything has been done very properly.
And then I will place my workhorse wire inside the LAD.
So the decision is to stop with 1.5 millimeter, right?
I think it's okay because there is not a lot of friction in the distal part.
Okay.
And it was not so difficult to cross this lesion. This is my opinion, is that the lesion is well prepared.
It's been prepared. Okay.
Do you think that with a burr,
samurai, please?
Do you think that with a burr of only 1.5 millimeters, that's enough for the left main, or you prefer to change with a big one burr?
Honestly, if I may interfere here, is that we already intentionally decided from the beginning not to rotoblade on the left main. You might remember that we have a 6 French guiding catheter here. I think to do something reasonable on the left main, we have to take a bar that is bigger than 2, I guess.
Yeah,
which
is a very big vessel.
With a 7.5, I think it will be
still okay.
Same. So I don't think we have a lot. We will have a lot of advantages to use a 175. So and we will use a non-compliant balloon of maybe 4.5 or 5. And due to the short lesion in the left main, I think it will be okay, but we will see.
We've had a request about the detail in the cocktail flush, Emanuela. I'm not sure if you can just take us through that.
So the detail in the cocktail flush was saline, heparin, and nitrates. That is what is used here in Toulouse.
And maybe the nurse can tell us the dose of...
the dose. What is the dose of nitro and heparin you put in there? 25, what? 25... is 25 milligram of Risordan, which is the nitrates they use.
10 milligrams of heparin.
Which is 10,000 units of heparin?
Yes.
10,000 in 500 cc saline? Pardon? Is it 1 liter or 500? Half a liter in 500 cc. So 10,000 units heparin in 500 cc plus 25 milligram Risordan.
I have to pay attention to this left main because the pressure is going down when I engage the guiding catheter. Sorry. And now I will place the workhorse guide wire inside the LAD.
So perhaps we could talk a little bit about the balloon strategy after rotablation and what size and what you're trying to achieve now, and what sort of balloons. Emanuela, do you want to give us your thoughts?
Yeah, well, actually, as you heard from the beginning, from the IVUS pullback, we have a landing zone of the LAD that is around 3 millimeters, 275, 3 millimeters. I think from now on, we have to complete our plaque modification that has been just started by rotablation. I would personally prefer to use now a 275 or even a 3 millimeter non-compliant balloon, do further plaque modification on the LAD. Then, as Nicolas said, we should try to modify also the left main. We need to discuss whether to stent first the LAD and then proceed to the dilatation of the left main, or complete the dilatation all the way through and then start stenting. It's something we can discuss together. But I would use non-compliant balloon. That's my personal preference. I know that other colleagues might prefer cutting or scoring balloon at this time, or even semi-compliant balloon. I mean, it's a matter of preference. My personal preference would be, having seen the amount of calcium, to use non-compliant balloons.
I think we can use a non-compliant balloon of 3 and 15 to treat the distal LAD, and then we will
tell us if you want some contrast. Huh?
We will use maybe a larger one in the proximal and also in the left main, in the proximal LND and also in the left main. Small test. I would like to place a wire inside the diagonal to try to keep it open.
Mm-hmm.
Maybe in a small branch. So we will do a small angio to better see. The pressure is quite good. Okay. Lionel, graphie. Okay.
Are there any questions from the colleagues from home? Are they quiet, silent?
There's a comment about this. There's somebody who missed the size of the burr that we started the procedure.
1.5.
They were saying, what criteria would you want to actually consider a stepwise approach? Is it, if, for example, you were unable to adequately deploy your balloon now, would you upgrade following that?
Why not? I mean, what is interesting is that Nicolas did not pull back the rota wire yet. The rota wire is still in the LAD. What he did, he just placed a workhorse wire next to it, and a third wire, another workhorse wire into a diagonal branch. So we are always on time to step down, well, to go back to rotational atherectomy and take a bigger bar, 175, not bigger than that. But I would give it a try. I agree with him. I would give it a try now with a balloon and see whether it opens up.
I keep the water wire, which will help me to cross the lesion, and also, if needed, I can perform
3 millimeter non-compliant balloon. 15, you said.
Oui.
In terms of balloon options, it's been helped by the IVUS at the beginning, which really gave us a good idea of how much bigger the vessel is than it looks angiographically.
Right.
We perform small injection to avoid any damage in the left main.
And I quite like this fact of having the rota wire still in place, because it helps improving support and pushability of our balloon, by the way. And it will work a little bit of a cutting device.
Like a screwing an angioscope balloon, but and also to deliver the stent. We can.
Excuse me. What is the length and the diameter of your balloon?
3 millimeter diameter. A length we use a 15 to start. We could also have used a 20 because there is tortuosity, and sometimes it's better to have a long balloon. But I think for this lesion, for those long lesion, 15 will be maybe okay, but okay, so I will start at this part.
Would be interesting to see now how this balloon opens up, and I would say at this point it's not
12
bad.
atmosphere. This is not a high pressure for this non-compliant balloon, and this is okay. So now I will go more proximal. There is no dog bone effect in the balloon. I feel some friction in this part.
One of our participants who have joined us wanted you to use a side hole catheter. Do you have any comments on that, Emmanuel?
For me, this can be a false, not a good friend, because sometimes you think the pressure is good, and in case of osteal lesion, you can induce damages. So I don't use it a lot because I fear to not good assess the good pressure. But I know some operator likes to use it, but for me, when you use a side hole guiding catheter, you have to pay attention to the injection who could anywhere induce damages in the osteal in case of osteal lesion. But this is my opinion.
Yeah, well, I agree. It gives you a false reassurance that things are protecting the left main, but actually not. It doesn't tell you exactly how the situation is, let alone the amount of contrast that you inject that is always higher than with this kind of guiding catheter we are using now.
And a general question, do you place a balloon over a normal wire or over rota wire when you use a ROTAPRO, for example?
Over the regular workhorse wire.
Yes, to have a better support, I use the workhorse guide wire. This is a
okay. In this case,
not extra support guide wire.
Okay, you delete the rota wire.
Yes.
Yeah, it's a sort of
there
rubbish.
There is no friction in the left
wire,
hand. I think it's okay.
Ballooning and stenting.
With the non-compliant balloon, I will just try to advance it after inflation. I think we can. In this part, there is some friction. I will do another inflation to be sure I have added.
This can be called the poor man IVUS. Actually, it's another way to assess the quality of your plaque modification. If the inflated non-compliant balloon goes, means that you have done a good job.
I have to say, all of the inflations seem to have been very adequate.
Right. But there is always a spike of calcium that makes progression of balloon and of stents, as we will see later,
at this time
difficult.
I didn't inflate inside the left main. My strategy is to try to advance the stent in the distal part and to manage the left main after. But because if I perform any inflation in the left main, I should stent first the left main and the distal part. And the pressure is quite good at this time. So if you agree, I will do like this.
I think I agree, because if you need to stent the left main, means taking back this beautiful supportive rota wire there. Since we have to put a long stent in the LED, this is the perfect situation to advance a long stent. So how about now stent selection?
As you can see, using the during the IVUS, the distal part is 3 mm diameter. So
about the length,
I think we can use a long stent, a 48 maybe.
Yeah.
And because due to the long lesion, and I think we have to treat the LAD and the left main with a full metal stenting. This is I think the best option. But we can discuss on that strategy.
Is it worth doing an angiogram after the non-compliant balloon inflation?
Yeah.
Okay. I just sorry. There is some. The pressure is quite decreasing. Okay. I wait. It's okay. And we have discussed a lot. So I just want to be sure there is no thrombosis inside the guiding catheter. I think it's okay. you can see the pressure is good, and there is the decrot wave in the descending pressure, so that means there is no devices and no thrombosis inside the guiding catheter, so we can inject safely. I will try to engage a little bit, and we will do a non-geo. Okay. Now I have to disengage and we will discuss, sorry. Okay, so you can see the 2 wires in both branch. We induce a dissection in the mid LAD with the balloon inflation. The size is increasing. It's good in this LAD.
It looks good. It's not a surprise to have a controlled dissection.
Yes.
When you use non-compliant balloons after ROTA.
Yes.
But of course with the stent you're going to put in, it rarely becomes a problem.
So if you're okay, we will try to advance the stent in this distal lesion, in this long lesion. In case of failure, we can use guide catheter extension. I think we will see, because due to the left main lesion, I hope we will succeed to cross this lesion with the stent. You know, there is 2 body wire, the rota wire which is inside the LAD, and also the other samurai in the diagonal branch.
Let's hope we can make it. A little bit down.
Yes, the pressure decreased because
it's due to the
guiding is being sucked in. Let's hope that we can make it with a 48 millimeter. I have the impression that it's going to be very long stented segment.
There's a question about using a slightly smaller diameter stent with a view to post dilatation. Would that be easier?
Well, you know, I'm not sure whether it will be easier. The point is we have selected the stent size based on the diameter of the vessel at the landing zone. So we feel quite confident that a 3 is the right choice. And by the way, there is no major difference between 275 and a 3 in terms of type of stent.
The stent is inside the left main, so I will advance a little bit the guiding catheter to be coaxial and to have a better pushability, a better backup support. And I push slowly the stent, and you can see it is crossing the lesion.
It travels really nicely. Yeah.
So I think
that's what I meant.
Not so bad. I will place it maybe. Sorry, I just want to check in the angio if I have to cover the bifurcation. Or maybe we have to do another angio. I think we will have to use 2 long stents. So the pressure is good. Okay. Injection. Oh, I think it's good at this part.
Yeah, it's very
I would like to avoid to cover the diagonal with 2 layers of strut. I think it's okay. So now it's time to remove the rota wire. And now if it's time also to do an ACT, because we are discussing a lot, and now I will just I want to check the anticoagulation. So after stent implantation, we will do an ICT because we are discussing. And so now at this time, the pressure is 14 atmosphere. There is no malexpansion.
Yeah, it looks very nice.
And due to the long calcification, I prefer to perform a test when the balloon will deflate to be sure there is no perforation, of course. So deflation, at the time of deflation, the patient had no pain, so this is good.
Just remind us which stent you've used.
Okay, it's okay.
It was a 348 drug-eluting stent.
I will remove the balloon slowly to avoid any damage due to deep intubation. So I pull back the guiding catheter. I place the balloon in the proximal part of the guiding, and now I engage again the guiding to remove the balloon slowly. Okay.
I would perhaps also pull back these guide wires a bit. They've gone a bit too deep.
Okay. Sorry. Yes. Thank you.
Someone has proposed a suggestion of using an anchoring balloon in the diagonal to give you a bit more support. Sometimes, I mean, obviously
yes,
you didn't need it here.
Of course, but
Yeah.
there is a lesion in the left main, so if you can succeed without any without too much device in the left main, it's better.
Yeah.
No, if you're okay, we will. The Reynolds fraction is good. It's less than 100 millimeter of contrast, so we can do another injection. I think it's okay.
Yeah, nice result in the LED.
And I think we can use another long stent from the LAD to the left main.
How about bigger than 3? What do you
I
think?
would like to perform a balloon inflation in the proximal left main using a non-compliant balloon. 4 non-compliant balloon of. Est-ce qu'on a un non-compliant 4? Non, un court. 4-15 non-compliant.
What was the pressure to deploy the stent? 15?
14 atmosphere. 14 atmosphere.
14, okay.
Yes.
Perhaps while we take the balloon, we may answer some questions there.
We've got a comment saying that somebody who doesn't use rotor will definitely go and buy one following seeing this case. Because they make the observation that a tough calcification, tortuosity, long lesion has been made very straightforward using this technique.
That is the beauty, and we were just commenting on this before with Nicolas off screen, that rotablator does not only disconnect the ring of calcium, but facilitate, smoothen also the coronary segment that is upstream to the calcified part. So that is why I suspect that this easy and smooth progression of the stent has been also made easier by the passage of the rotablation bar.
Would you consider another IVUS just to get the length right between the stents in terms of measurement, or you're going to use a balloon inflation?
I will perform a balloon inflation in the left main. I think it will be enough to assess the length, but we can also use an IVUS. I would like to try to block the ostial lesion with the balloon, and then we will decide if we do an IVUS or if we implant a stent. This is a 4O balloon, non-compliant balloon, 15 millimeter of length.
So it's a good point that you've got a lot of calcium, but in a very large caliber vessel. And yet the limitation perhaps of the rotational atherectomy system is the 175 2mm burr. You've been, are there other technologies you would consider, Emanuela?
I think you're alluding to the lithotripsy balloon, I guess. That could, do you hear me?
Yes.
That could be an option in this large diameter segment. I've heard of colleagues having performed this therapy in large vessels with good result. I personally have limited experience with that, but that could be an option.
20 atmosphere, 4 millimeter balloon. We'll go fast because the pressure is going down decreasing
this time, and not because we are damping.
So now I will remove the balloon. I will wait to.
It is a balloon of 3.5?
4 and 15.
Okay.
Non-compliant balloon, and I disengage also the guiding when I remove it. Okay, the pressure is good now. It's 140 millimeters, so it's okay. Yeah. And if you want, you can. If you have enough time, we can assess the length with an IVUS.
I think do what you would normally do.
Yeah.
I won't do an IVUS.
You know what? This radiopic part of the wire there in the diagonal, how long is that one, Nicola? It's about 4 centimeter, that one. We could just pull back that one a little bit, and with that assessing the length of the proximal stent. Yeah, like this.
We can record this if you want to assess the length.
Yeah, cool.
I don't think we need
Yeah.
So I think we have to use a 48
Yeah.
length.
From where to where do you want to send, Nicola?
And do you use a nitrate to know exactly the diameter or not? Do you know with IVUS only, and it's not important to add a nitrate?
It's always important to add nitrates, but actually in this case we are quite confident that whatever stent will be, it needs to be bigger than 3 for sure.
I think we can use 4
up to 4.5.
40 and 48.
Yeah.
We will inflate this at very low pressure in the LAD, and then it will be easier to post-dilate the left main.
There's a lot of nitrate going in, of course, when you rota with in the flush.
Correct.
Yes.
So sometimes intracoronary nitrate, as well as that, can sometimes lower the blood pressure.
Because the 4O synergy is easier to post-dilate at more than 5 mm. I think this is a quite huge left main, more than 5 mm, and we'll do a post dilatation using a 5-0 balloon inside the ostial and mid left main. So I use a long stent. I repeat the size. Diameter is 40 and the length is 48. To better place the stent, I can use stent boost. So I think it is not so bad. This okay, stent boost. Okay. According to the calcification, we are not so bad. We will assess at this time. The pressure is good, and we will assess if we cover the left main. So I advance a little bit the guiding. Yes. Test injection. Oh, I think it's okay. At this time, I will inflate. I repeat, I do not cover the circumflex artery because this is not diseased and the angulation is quite good. I inflate at low pressure. It's about 6 atmosphere. 8, and then I will manage the post dilatation using a larger balloon because I don't want to induce to oversize the implantation in after the diagonal. So I wait, the pressure is going up now, okay, and I will pay attention to remove slowly the balloon because I have to avoid a deep intubation of the guiding inside the stent. I have to wait, the patient is moving his hand. Okay, on the screen it's okay. So I remove the balloon. We will check if this is okay in the diagonal because I don't remember if I said before that I think we have to keep it open with a wire. I don't plan to perform any kissing also in the diagonal. I just want to open the circumflex artery. So at this time, I would like to perform a post dilatation using a 3.5 mm balloon. We used before a non-compliant 3.5 balloon, so I think we can perform a post dilatation in the proximal LAD, and then we will use a 5 to perform a post dilatation inside the left main. Are you okay?
Yeah, it's a common myth. A common myth that people think that calcification protects you from perforation. But you need to be very careful and make sure you do get your sizes correct, as balloon perforation post-rotor and stenting can still happen.
Right.
Okay. I am coaxial with the stent, and I think there is no longitudinal compression. This is okay. So I will engage slowly a balloon inside the proximal LAD just before the diagonal to perform a pot, proximal optimization, a post dilatation inside the stent between the ostial LAD and the diagonal. So now slowly I engage the balloon inside the left main and the LAD, and then I will change the view.
3.5 non-compliant balloon, Didier.
I have
3.5, okay.
Yes, I forget because we are discussing, and I have to perform a post dilatation also
of the left main, huh?
in the overlap between the two stents. So first, I perform an inflation using a 3.5 balloon at low pressure. This is a 6 atmosphere. I think it's okay. Just in the overlap part, and then I will perform a pot more proximal. Okay. I think.
Any idea, Didier, for the balloon of the left main? We may start to ask preparing that. 5.
Yes. And if it is okay, I will try to remove the wire in the diagonal. So it's first, before doing the second pot in the left main, I would like to perform an angio to assess the diagonal. Okay, this is
Not
okay.
bad,
So due to the fact the wire is trapped in a long part of the stent, I will use a torquer to remove the wire, and thanks to that I turn the wire because I would like to avoid any deep intubation of the guiding catheter. So as you can see, I spin the wire just to remove it slowly, and thanks to that it avoids, I think, to engage the guiding and maybe induce longitudinal compression in the proximal part.
That's a very
now
useful
it's time to perform a proximal optimization with a 5.0 balloon in the left main, and then we have to assess the circ, and we'll discuss if we have to open it or no.
Okay, so we didn't protect left circumflex because there was no lesion at the ostial part.
Correct.
Yes, and the angulation is 90 degrees, so the risk of occlusion is I think is very low. I pay attention because the 5.0 balloon is quite stiff, and I want to avoid any damage of the stent. It's okay, and by caudal view I will assess the circ to place the balloon in the right part. Lionel, can you please inject, test? Okay, so I'm just before the carina. I will inflate. Okay, slowly. The pressure is 14. Okay, and now I will perform another inflation in the ostial part, because you know in case of ostial lesion, this is not only atherosclerosis in the coronary arteries, it's also atherosclerosis in the aorta, which is less thin. So the resistance is very important. So I prefer to inflate at higher pressure to be sure the stent is well open, and also we can do a stent boost to be sure everything is okay.
I can feel the bifurcation, the bifurcation mafia beginning to ask me questions. There's somebody who wants to strut towards the circumflex opened with a kissing balloon.
Okay, no problem. I will use the balloon to engage the guiding inside the left main, as you can see, and we will assess if the pressure is okay. The pressure is not decreasing, so I think it's quite good. And we will assess if everything is okay, just for safety reason, because you know the RCA is occluded, and then we will discuss and manage the bifurcation. I will, okay, by cranial view we will assess the LAD2. Okay, so injection.
Very nice result.
Okay, this is not so bad in the left main and in the LAD. The diagonal branch is open, the TIMI flow is 3. We lose no septal branch. Also, the small second diagonal is open. Maybe we will perform another balloon inflation in the ostial part. I'll change the view and we will assess the circ.
Ready?
As you know, I am engaged inside the stent.
Yep.
So
actually, it's not bad, the ostium of the circ.
Yes, it's not so
remained
bad.
exactly untouched.
So usually we open the large branch because in the future we can have.
So you do it by default, actually.
Yes,
okay.
if we have to treat in the future the circumflex and the marginal, but you know this patient is 80, so we can also accept this result and just follow.
Perhaps what could be useful, it's just to do a run with IVUS. We assess the stent.
Yes.
And we can also keep.
We will do an IVUS and we will decide. What is? How do you feel the result, and what do you think we should do?
Well, it's an astonishing result. You should be very proud of an incredible demonstration of how to look after severely diseased, diffusely calcific disease of both the LAD and the left main. I think the IVUS would be interesting and educational, although I appreciate it may not be something you would normally do after going up with a 5mm balloon. Perhaps while we're doing that, could I ask you, Emanuela?
Yes.
Just a comment, the ACT is over 400, so we don't have to add any heparin.
Perfect.
And we can continue safely. Sorry.
We've had a question that, let's say you thought you had prepared the lesion, and then you put your stent in, and in fact it turns out there's still quite marked indentation. So in fact you have so there's a question about what action you take if the stent didn't fully deploy in a calcified lesion because of lack of preparation.
Bad luck. Yeah, that's bad luck, of course, but it's a bad luck that we could always anticipate.
Yes.
By doing adequate plaque modification. Well, one possibility is to use high pressure balloons, but as you said, the risk is always to have a vessel rupture even behind the stent struts. That can always occur. We might think to do stent ablation as well. This has been performed, even though it's a kind of technique that I wouldn't recommend for colleagues who are starting having experience on this.
We have published a short theory of stent ablation using rotablator.
Yeah.
If you do this, you have to pay attention to you have to be sure that your stent is well opposed.
Yeah, correct.
And this is only a dog bone effect, and you have to manage only a mal expansion, but there is no malapposition, and thanks to that, you will only broke the fibrosis and the under-expanded strut, not all the stent.
Shall we have a look at this IVUS, Adam? Do you have it?
Yes, we're admiring it.
Yeah, of course, it's an illusion to think that we will have a perfectly circular stent. Let's not forget that the amount of plaque and calcification was extremely eccentric. So I think having a well-opposed stent with a good diameter overall will be more than a decent result. But you see it is well expanded everywhere.
We are inside the left main at this part.
Yeah, we should be able still to see the carina. Did we already see the carina?
Yes.
Okay.
We will
play it back and then we can check it together.
I will just assess the ostial part.
It went too quick.
Sorry,
we can go back again.
We will do it again.
Yeah, at least
for the left main, yeah.
Yeah, at least for the left main because we lost the.
Maybe we can just
do it manually
by direct view. Yeah. So I am.
Yes, there you are.
Okay, so.
And you didn't inject systematically nitrate after stenting before IVUS again? Huh?
No.
So we do sorry. My probe is not in the right good place. So at this.
Yeah. There you
go again. I start a full back.
1, 2, 3,
you will
4
see
and a half.
The ostial part, which is this is the calcification.
Yeah, it's highly eccentric.
I think we should perform another inflation at higher pressure.
I agree.
So I will use another the same 5. So just to be sure, are you okay if we don't manage the circumflex artery?
Yes, I
if
mean,
we don't do any kissing, or is it okay for that?
There's quite a lot of trial data showing that you've got TIMI3 flow with no restriction to the circumflex. It looked really quite a very good angiographic result. You wouldn't go up to that.
In my mind, I prefer to stop because after you have a difference of caliber between
I just want to assess the size of the
LID and left
in the mid part.
circumflex.
Tu peux mettre en milieu là le tronc, il fait combien? 5,5 ou pas? Avant. Sorry.
So there's a question about pharmacology.
Okay, a balloon 5.5, it will be better. A balloon 5.5.
We follow you, Adam. Please go ahead.
There's a question about pharmacology, and because there's diabetic and extensive debulking and stenting, would tirofiban or a similar antiplatelet glycoprotein drug be helpful?
How did you prepare this patient, Nicolas?
With ticagrelor, aspirin.
Okay.
And we use a lot of heparin. As you know, ACT is over 400.
Yeah, I would also have used, more potent P2Y12 inhibitors like ticagrelor or prasugrel. I wouldn't have personally used diaorphiban, much like Nicolas is doing here. We didn't have any impairment of flow during the procedure, even if there is extended stented segment here. I think it would be fine. It would be enough. I don't know how about you. Would you give 2B3 inhibitors here or just keep it like this?
No, we don't use it.
Yeah.
It's very uncommon. Only for patients with flow
impairment during the procedure.
Thrombotic STEMI, a lot of thrombus, and in case of inability to eat platelet, if we fear that the new antiplatelet therapy won't work, we will use parenteral anti-GB2A.
I think, Didier, you were busy studying this aspect, right? To give novel P2Y12 inhibitors in patients treating with a rotational atherectomy.
Inhibitor? I didn't catch.
So, okay.
No, I think you were busy with a study investigating the role of new P2Y12 inhibitors in patients treated with rotablator.
No.
With new
with the ticagrelor. Yeah.
This is a 5.5 millimeter balloon, non-covalent balloon at 20 atmosphere.
Okay.
I think this is well open. We will do this in another view. Okay, maybe in this view it will be okay. I have to wait. The pressure is okay.
I don't know the percentage, but in general, when we have a complex lesion with complex patients, we prefer to use ticagrelor than clopidogrel because you are sure that you have a higher antiplatelet aggregation. And in general, it's our habit to use ticagrelor is better probably than clopidogrel if it is possible. And for this patient, it is sure that in my mind, the best option was to give ticagrelor before the procedure than clopidogrel because we probably have a little percentage of low flow after rotablation, and with you decrease the risk of thrombosis with ticagrelor.
Okay, I think what we would do in the next few minutes is to have a final look with Ivus, and then I think we can have our closing remarks, if you agree, Adam and Didier.
No, yeah, well, timing's very good. We've got 5 or 6 more minutes,
okay.
And so I think the final Ivus would be great. There's the questions have changed to comments now about what a perfect case you've done here, Nicolas. So. I think
so. I am in the left main. You can see the Ivus. I start the pullback.
We can switch to Ivus, perhaps. Yeah, big screen Ivus, small screen angio.
There's been a comment about whether the ostium of the left main does have any stent struts.
Yes, it have. You can see there is a strut inside the aorta. At this time, at this part, you can see strut.
It is definitely improved.
I think this is okay.
Yeah, I think so too.
No,
so we can do the. We.
Okay, you are sure because you have
dilatation with 5.5 non-compliant balloon. Okay.
Okay.
So
and
now we will do the final shot. If you want to discuss, we have some cases or some tips and tricks to share.
Just a tip and tricks, Nicolas. When you have an ostial lesion of the left main, you prefer to have some struts in the aorta to be sure that you cover all the ostium.
And you have to place the stent to cover the roof of the left main by cranial view, left oblique anterior cranial view, sometimes only cranial view, but you have to find the best way to assess this. You can see this is well open. If okay, I think it's okay. The patient is quite tired now because
and you have a good pressure. Yes. When you are engaged with the catheter.
I am not. I disengage a little bit the guiding, and we'll do another angio to assess if we cover everything. I think it's okay.
Yeah, it is really good.
You can see we cover everything. The circ is okay. All side branches are okay. I think we can stop if you agree with me.
Well, congratulations to both you, Nicolas, and Emanuela, and all your team for astonishing demonstration of how to look after severely diseased calcific artery in this elderly patient in the contemporary era. Fantastic demonstration of the new equipment and great education using all the modern techniques, and the imaging was outstanding. We're just going to finish off with the last case. Can we go back to the slides, please? Okay, this is a case done, in fact, by the unit in Toulouse here, and it was transferred in fact, in the last couple of weeks or so, where you can see the angiogram of a very tortuous calcified ostial obtuse marginal, which was treated with balloon therapy. And in fact, you can see some of the intervention on the right-hand slide. And the final result of which there was extensive dissection, you can see, of the first high obtuse marginal, which was caused by an injudicious placement of a wire, and then a complete spiral dissection due to untreated calcium of the obtuse marginal. And this was transferred to Toulouse for rotational atherectomy treatment. And because of the tortuous nature of the lesion, it was done in a very stepwise, careful way of dealing with the proximal lesion first, and then on the second run, eventually got down to debulk the origin of that second calcific marginal, and was able, after some stenting, which I think is coming up next. And you can see that the first marginal artery has now been fully stented, and the second marginal artery has also been stented, I think with the help of a bit of support from a guideline, a catheter. And it really demonstrates that if you don't prepare calcific, complicated lesions properly, then you'll end up with significant complications. And those of us who are committed to treatment of calcific lesions turn to this technology quickly and early, because it makes complicated cases much easier. And I think the new technology that we've seen on this webinar will certainly make the take-up and practice of rotational atherectomy very much easier. So thank you to all involved. Thank you very much to Professor Carrier here.
Yeah, the conclusion should be that you can use rotablation or ROTAPRO not only for undilatable lesion, but also when you have a very calcified lesion, and it is very important to think to use rotablation in first intention before balloon PCI. And in this case, you can see that you could avoid a big dissection or an occlusion of the artery if you use rotablation in the first intention to avoid these complications.
My thanks to Boston Scientific and Liliana Vitorino in particular, and all the great team of people in the background who work for EduPCR and the EuroPCR team who have made this webinar. I hope you've enjoyed it. Thank you for joining it. It's been an amazing number of questions, which I hope we've been able to answer adequately. Again, my thanks to the operators for an astonishing job, and have a good weekend. Okay.